In treating dental students, I found that what was in the didactic lectures did not translate well into the clinic. So therefore, I developed what I referred to as a treatment-focused diagnosis, or a TFD. The first thing we need to look at is what should be included in a periodontal examination and treatment plan. First, we need to know the clinical signs of periodontal disease, the predisposing or etiologic factors, what is a diagnosis, what is a prognosis, and what are the treatment options. Here we have 6 blocks dealing with various aspects of the examination. It's not the purpose of this tape to go over all of the clinical signs of periodontal disease or the predisposing factors. We're going to focus on blocks 3 and 4, which focus on a quantitative way of determining bleeding on probing and what I refer to as the treatment-focused diagnosis. Like blocks 1 and 2, the focus of this tape is not on blocks 5 and 6. 5 and 6, to me, is self-explanatory. Exactly what you do for health, what you do for gingivitis, and what you do for periodontitis in your treatment plan. Block number 6, I think, is rather unique. For all patients are interested in improving the quality of their breath. And by looking at 2 videos on the web textbook, one of them is on the least expensive, most effective mouthwash, and the other is on the importance of cleaning the tongue. The importance of cleaning the tongue, you should be aware that after you do a good job of brushing and flossing, 90% of the bacteria left in the mouth are on the posterior third of the tongue. This cannot be brushed without gagging, and if this material is not removed back there, not only do you have excessive numbers of bacteria left, but you also have sulfur-forming bacteria which attribute to bad breath. Students' responses when asked the question, what is the periodontal diagnosis? Again, translating what they get in didactic lectures and what they do in the clinic was not clear to the students. 100 students were randomly asked, what is the periodontal diagnosis? 45% said bone loss, 10% said calculus, 30% said plaque, 15%, only 15% said gingivitis or periodontitis. So let's see how we attempted to teach them what they did not learn in their didactic lecture. Let's look at the student treatment options on the average patient coming through the periodontal treatment. Whether the patient was healthy or diseased, when asked what the treatment was going to be, 100% of the students said scaling and root planing. They didn't seem to understand when scaling was indicated or when root planing was indicated. And when asked if there was bleeding on probing, all students said their patients had bleeding on probing, when in reality many did not. So determining a treatment-focused diagnosis, number 4, we have health, and health is basically no bleeding on probing, no suppuration, and no pockets. This patient simply needs the treatment of what's often referred to as a prophy, removal of supragingival plaque and calculus, and reinforced home care if necessary. Much discussion went on with various faculty members in dealing with health with attachment loss. This is a patient that has generalized recession interdentally as well as facially, and generally this is a result of periodontal surgery. There's no bleeding on probing, there's no suppuration, and there are no pockets. So what we're dealing with a treatment on this is the same as a healthy mouth, and basically even though there's attachment loss, we're going to just do a prophy on this particular patient. The dilemma: what if we have superficial redness, bleeding in areas of recession, but have no probing depth? What is the diagnosis? Basically, this looks like a gingivitis, but when we have attachment loss, the true diagnosis on that is a periodontitis. Gingivitis. We're all familiar that there should be some bleeding on probing. Pockets are present from swollen tissue, but not from attachment loss, and the treatment is scaling and polishing if slight to moderate. If you have a severe gingivitis, perhaps you may want to do a gross debridement, reinforce home care, and follow that up with scaling and polishing. But this is not treated by scaling and root planing, only by scaling. And oral hygiene instruction certainly is necessary, as well as a follow-up reevaluation. Treatment-focused diagnosis. Let's now go to patient number 1. This patient has a slight generalized periodontitis. The treatment, scaling of the entire mouth, oral hygiene instruction, and reevaluation. Very clear to the student exactly what they need to do. They're not going to be doing any root planing. There is no attachment loss. So we scale the entire mouth. We do no root planing, oral hygiene instruction, and reevaluation. So, gingivitis, generalized, slight to moderate, that is the treatment diagnosis, and the students are encouraged to circle this on the sheet that they are given. Patient number 2 has a localized gingivitis. Now, what does that tell us? We're not going to be doing any root planing. The rest of the mouth, other than the lower anterior, is healthy, and the scaling is going to be focused on the lower anteriors, and the rest of the mouth would be treated as a healthy mouth, and a prophy would be done. Patient number 3. Patient number 3 has a periodontitis. It's localized, and it is slight, and it is in the maxillary molar areas. What does that say? The mouth is healthy except for a localized periodontitis where there is attachment loss. We also know that this is a case that is not going to require surgery, that the treatment can be completed with root planing, and we need to obviously follow up, reevaluate, and reinforce home care. Patient number 4. Patient number 4 has a generalized slight periodontitis. So therefore, root planing is going to be done throughout the mouth. Patient number 5. Patient number 5 has a generalized moderate periodontitis. We do not know in this particular case whether surgery is going to be necessary, but we know we're going to do initial preparation, and basically with a generalized periodontitis, we are going to scale and root plane the entire mouth. Patient number 6. Patient number 6 has a generalized severe periodontitis. Yes, we're going to do initial preparation, and in all probability, the patient is going to need surgery, and this is a patient that perhaps should be referred to the periodontist. So now the student begins to get an idea exactly what they're looking at and how to deal with it. Now let's look at patient number 7. This is a typical patient in a general practice office who has periodontal disease, and from the treatment-focused diagnosis, the treatment would be completed there. The patient would not be referred to the periodontist. The patient has a generalized gingivitis. What does that tell us? That we're going to scale the entire mouth. But the patient also has a localized slight periodontitis in the maxillary molar areas. So this is an area where we're going to do some root planing. And we're going to give oral hygiene instructions. We're going to come back and reevaluate. But with a slight periodontitis, this is going to respond nicely to root planing without any surgical intervention. What about bleeding on probing? We want to quantitate bleeding on probing. Slight bleeding on probing is a trace. It's delayed. It means there's minimal inflammation and therefore not very significant. A typical on this would be on the mandibular left, you probe tooth number 18, you see no bleeding on probing. You probe tooth number 19, you see no bleeding on probing. But when you get to tooth number 20, maybe on 18 or 19, a little blood has oozed out. Really not significant, but we do need to be aware that there was some bleeding on probing. Moderate bleeding on probing is spontaneous. and it means there's a greater inflammatory response and a more significant clinical finding. In this case, let's say that you place the probe in a pocket and it measures 5 millimeters, and you withdraw the probe, and as the probe is withdrawn, blood follows that out. Severe bleeding on probing is profuse and persistent and means there's a greater level of inflammatory response. In this case, typically the tissue is somewhat swollen, reddened, and as you begin to probe, before you even reach the depth of the pocket, blood oozes out. So this is a good way for students to learn a quantitative way of doing bleeding on probing. Now let's summarize what I hope you've learned. We've got 6 factors on this flow sheet. The first 2 factors, the clinical signs of disease and the etiologic factors, we did not discuss. Our focus was on number 3 and number 4, quantitating bleeding on probing in the treatment-focused diagnosis. On the bottom, 5 and 6, we must touch on slightly. The treatment options are quite obvious. Let's focus on number 6, treatment for bad breath. This is something all patients are interested in, and very little is addressed in this area in most dental clinics. So to be effective on treating bad breath, halitosis, malodor, or whatever you prefer, please go to the web textbook and look at the least expensive, most effective mouthwash, one video, as well as the video on the importance of cleaning your tongue, because most bacteria associated with bad breath are on the posterior third of the tongue. It is my hope that if you will incorporate this in undergraduate teaching in your dental school, if you're a teacher, you will find the students will have not only a much better understanding of what they're trying to accomplish, but will also have a greater appreciation for periodontal therapy.